Hello and welcome everybody to the final week of Rev Up 2020. Thanks for joining us. I'm Ryan Schonecker, the SVP of Sales and Marketing for Revel. Today's panel session is called The Bold Innovation of SDoH and What to Expect Next. So before we jump in, we're going to do a quick discussion about what we've seen so far over the course of the last 4 weeks. And also just a reminder to everybody, if you'd like to ask a question in today's session, we're going to be doing a Q&A at the end, but please ask the questions throughout. Use the Q&A feature on the bottom of your screen to do that. Also, we're going to be recording today's session. It'll be posted at revupshow.com, which is where you registered for this. There will also, as usual, be a brief survey at the end of today's session. So please fill that out. We really love the feedback. And it also, you'll be entered for a chance to win a $100 donation to the charity of your choice. If you're into tweeting, we're going to be live tweeting the event today. So please join the conversation at hashtag RevUp2020. And with that, let me give you a quick overview. So for those of you who this may be your first week joining, way back, which feels like a long time ago now, on August 4th, we had Dr. Rishi Manchanda join us and share with us the upstreamism. So we'll be talking about SDoH, and he's the person who gives it the label upstreamism. And he talked to us a lot about the different things that make us sick and what we can do about that. On August 11th, we had Robin Roberts lead a panel discussion about personalization in healthcare. Talked a lot about how personalization can be successful when we think about people as unique individuals, and how can you actually apply that and that balanced approach and that balanced need within your business. On August 18th, we had Jared Johnson lead a panel for us talking about innovation and member experience. And this conversation covered a lot of ground, but really was focusing on the need for collaboration and humanity in healthcare. And there's a lot of discussion around that, which was great. Last week, on August 25th, Sarah Ratner led a panel for us related to SDoH, up close and personal. So that session was talking about individual needs, requirements, and innovative approaches that plans are taking on, and this combination between payers, providers, and some of the things that people are doing to try to bring forward what really could be innovative and helpful for people now in the world of COVID and in the future as well. So I just want to say thank you to everybody for your attendance, for the feedback that you've given, for your engagement throughout this. Again, for all the winners that we've given out for charity. And we really hope that next year you can join us in person, we're all hoping for Rev Up 2021. I also like to give a big shout out to the marketing team. Thank you so much for all the effort that you put into pulling this together. And with that, I'm going to turn over to Pierre Vigilance, who's going to moderate today's session, introduce you to our panelists, to kick off our capstone event. So thank you very much, everybody. Again, please feel free to submit questions throughout. And Pierre, over to you.
Thank you, Ryan, and good afternoon. Thank you for joining us, and thank you very much to the good people at Revel Health, Ryan, of course, Jen, Amanda, and the rest of the team for engaging us in this timely conversation about social determinants of health, and to close out the last 5 weeks of what sounds like they were very rich conversations on this very important topic. Social determinants of health is obviously going through and has been going through, I don't know if it's a renaissance or a revision, if you will, but there's definitely a lot more attention being paid to it and a lot more people talking about it, not only from the academic side of things, but also from the practice end of things. And the application end is what we're going to be focusing on today. I'm very happy to be joined by three very knowledgeable guests in this space. We have with us today Jennifer Spear, a population health strategy lead for Bold Goal at Humana, as well as John Gorman, who is the chairman of Nightingale Partners, and RJ Briscione, who is the senior director for social determinants of health strategy and execution at CVS Aetna. All of them bring with them a wealth of experience, not only in sort of healthcare, but also very specifically in this social determinant space, which has been the theme for the last few weeks. And given all that's going on in the world with respect to COVID and this conversation that we've had around race and equity, the social determinant element of things is definitely not going to be going away anytime soon. So we look forward to a great conversation today. So thank you to all of you for joining me and the Revel team for this conversation. So I wanted to open up with this question about impact and outcomes. So impacting outcomes obviously begins with effective engagement, which has its roots in understanding communities. And understanding communities needs to happen not just at the surface level, but at a very granular level. And for all of you in your work, you try to get in there and understand exactly who it is you're serving, what it is they have a need for. And that's not easy. And it's certainly work that is very time consuming to some extent, but it's very necessary. So the question I have for you is, what moves are you making within your systems to improve your understanding of the communities you serve, so that you can design better interventions with them? And so if you wouldn't mind, Jennifer, if I could start with you, at Humana, what is it that you're doing to try to get to know and understand your communities better?
Sure, thanks, Pierre. So, when we really started this work about 6 years ago now, we did so with the intent and very specifically going deep into those communities that we were serving, starting with San Antonio, meeting with health departments, community partners, academic institutes, all of the organizations that were impacting health in any way there, to really understand the needs and the priorities. We've taken that approach with all of our bold goal communities, really having boots on the ground, hiring a resource there. That's really what they're looking at. And we know every community is different. While diabetes might be a major condition in every community that shows up, the way that you address it is different depending on the population that's there, or cultural competencies in the community, all of those sorts of things. And so we can't address it broadly. So that's really where we started, knowing that, we have those boots on the ground, 16 bold goal communities now. We also know that we need to just better understand our populations in general. And those populations outside of those 16 communities, we have national presence. And so working really closely with our partners at Rev Up, actually, on a comprehensive screener to really screen members and get that critical mass to understand, what health-related social needs they are experiencing, to really understand how that impacts their conditions, their management of those conditions, their healthcare costs, really to get that broader picture so that we have the data and then are informed not only to understand the community itself, but just also the members within it and our Humana members, and what they are dealing with and how it's impacting their health in general.
Very good. And I remember in our conversation, RJ, in sort of relation to what Jennifer was just talking about, you were talking about some work you're doing in the food space in Florida and how, if you just design a program and throw it out there, you may not be taking into consideration that people are carrying many pounds of groceries a significant distance in order to get them from the store to home. Can you talk a little bit about the experience or the moves that you all have made to try to dig in and understand a bit better from CVS's Aetna's perspective? So.
Yeah, sure. Thanks, Pierre. And thanks, Rev Up, for having me. Great opportunity here. A couple things on that. What we did is a school pantry program in South Florida, in Miami, where we not only sponsored for this school to have the pantry, because what we learned ahead of time from Feeding South Florida was that we really needed to concentrate on feeding the family. They've had some data on we've seen and heard of those backpack programs where you send the kid home for the backpack. Well, the backpack gets cannibalized pretty quickly. And then, so we built it around the whole family. I think that's actually something we're going to talk about a little bit later too. But we really wanted to engage the whole family in that food process. But the thing I learned the most was just standing out there and watching people leave. So we're distributing like large fruits and great produce and all sorts of wonderful things from Feeding South Florida there. And people are leaving that elementary school, and they have, most of them have no transportation, or they have like one shared car for the whole family, and that person is off on their way to work, right? And so the rest of the family is walking home with that. So the big learning that I put together for our internal folks there was that one, social determinant does not happen in a vacuum, right? So we thought we fixed their food needs, and we did. We measurably improved their food insecurity. But then when you watch, they either have to walk that home or they have to share for a ride, and it's hot and it's not easy. And so then maybe they're leaving some of that food home. so that's, that's something that we're actually solving for in the next instance of this, where we're going very micro-targeted, super local, which we're glad to do. And then secondly, I would say that we're really getting into to the question on community data as we work with, we have Unite Us as a partner for a referral platform in 4 cities for Medicaid, 2 cities for our D-SNP members now. But what we've learned that we really need to do is get not only community level data so that we understand that as a member of the community, especially as CVS Health, and see what those social needs are. And so we have both internal and some external sources that we're partnering with on this. We're using socially determined in conjunction with Revel to turn our members out. So we'll take the very specific data on each member and their index related to a specific determinant, and then using Revel to turn that member to the platform. So both very specific and then also available at a community level as we think about how to engage with the community.
So as you, John, as you hear these interventions and listen to this from the perspective of being an investor in social determinants, what are the things that come to mind from your perspective? Because you have a slightly different angle on this than RJ and Jennifer.
I mean, and by the way, thank you, Pierre. It's great to be here with Jennifer and RJ as well. It's just always a pleasure, guys. And thank you for the opportunity to actually put some real clothes on for the first time since March. Oh, it's nice to be back in some professional attire. We take a very similar approach that both Humana and Aetna and CVS do. And, with every project that we're going in and investing in, and in some cases standing up these interventions ourselves, you can, the first takeaway that you have is that you cannot understand a community enough. You have to be intimately familiar with the territory into which you're going to try to intervene. And, so every project that we look at has to begin with a really robust data collection and analytics run, to get to ultimately what we call a social health profile for everyone in the community in which we're trying to intervene with. So, in our process, we use an analytics engine that looks at over 5,000 different sources of publicly available data to really give us a very intimate understanding of what's going on in a community, all the way down to the individual and the household level. And then that information is then made even more robust when you factor in the plans, medical claims, pharmaceutical claims, lab and radiology data. Now you have a very rich health and social profile for everyone in that community. And one of the things that we work on, especially if it's a health system or a health system owned health plan that we're working with, is the eventual collection and establishing an electronic social record that would sit on top of an electronic medical record and be agnostic as to whether or not that's, Epic or any of the other vendors that are out there, so that you can see all of the social information that's available on that patient as well. And that the ability to then aggregate that data up to a community, to a neighborhood, and then to a broader geography really is what's absolutely necessary for us as investors to ensure that we're spending our money where it's going to be spent most wisely to impact the population that we're really after. Embedded in all of that and implicit in it, Pierre, of course, is really intimate cultural and linguistic competency with anything that you're going to try to do long before you do it. I'm always just sort of haunted by remembering my mom, who's a primary care physician who always worked in underserved communities, had this case where Mrs. Ramirez, who didn't speak a word of English, gets sent home with her cardiac meds, and the label says take once daily. And to Mrs. Ramirez, who speaks only Spanish, we know what ONCE in Spanish means 11. And just having something as simple as a pill bottle mislabeled for someone with a language challenge can really dramatically injure somebody or worse. And that kind of competency is critically important in the design of any kind of social determinant intervention, because, as I always like to say, it's like social determinants are just 4 fancy words for poverty. And if you don't really intimately understand the poor folks that you're really trying to help, all the way down to language and basic little cultural unique qualities that they live with, you're never going to have any success trying to intervene with them.
Right. And that's actually a good pivot, because the opportunity to engage and serve communities is not only that of corporations like the kind that you're all a part of, but also community-based organizations, which are often themselves funded by foundation dollars, philanthropy dollars, and operating on thin margins. I remember when I was the health commissioner in DC, as well as in Baltimore County, we deal with a lot of different community-based organizations who were getting funding from organizations that may or may not have had mission alignment with the health systems that they were serving the same population as. So how do you, and I'm going to start with RJ on this one, from Aetna CVS's perspective, when you work with community-based organizations, and that's one part of your work, obviously, but then do you also make any attempt to work with the people who fund those CBOs so that there can be alignment with your mission and the community's mission and alignment with them at the same time? Is there any work that you're doing in that space? And then I'll come to you, Jennifer, for it.
Yeah, sure, very much so. And I think we're on a new frontier in this, actually. So a couple of things, the example of what we did with Feeding South Florida, that was a grant investment to kick it off, right, to get that done. But we paired that with a academic study, because what we want to do is take things like that, learn from them. We didn't do that specifically for our members. That wasn't designed around Aetna members. That was designed around a very Medicaid-like population. Again, looking at some of the data that we talked about earlier, similar to what John mentioned. We want to take a couple stages of learning from that and then move to be able to apply it to our members. So we're funding those organizations as we do that and learn from them and learn with them. We can never recreate any of this that they do on the ground, right? And so I think we're at a really cool pivot moment here, where when you think about that kind of instance coupled with where most of us are going, and I've spoken with folks from all the large insurers as well, with the social referral platforms, which organize the CBOs in a given area into a network, right? And so to be able to have that data and understand what the value that those CBOs bring, I think the opportunity is there, and it's probably a once in a generational opportunity, right? SDoH is super hot now. But we've got a unique chance to get this right so that we can actually pay those community-based organizations for value. I think it makes a lot more sense to pay them for the value that we understand from the data and analytics that are driven from these platforms, which is frankly why the CVS, Aetnas, and the Humanas of the world are paying for these platforms, is to get some analytics off it and understand this whole world of social determinants. It'd be a shame to try to come up with some sort of fee-for-service schedule on every possible thing a community-based organization could do. I don't know how I'd go about doing that, but I can, we're very early on in this, but I can take that data someday in the next few years and say, this is the value that this is unlocked, either in quality improvements in our population, cost improvements over what those members had before, and pay those community-based organizations. I think that's a real change for them. And I think from talking to many of them, I think it's a positive change to go from grant-based funding, which we do plenty of now, to a true value-based arrangement for them.
Good. And from your perspective at Humana, Jennifer, is the approach any different, or is it very similar to what RJ just described?
Yeah, I would say very similar to what RJ is describing. It's been a challenge, if you will, to really get business leaders to understand the value that these community-based organizations can bring, coupled with the need to help them build capacity. So if we're looking, for instance, at a meal delivery program, and we want to do that with one of our food bank partners, they can't go get the loan to buy the van, to hire the chef, to build the kitchen. That has to be built in up front. They need that money up front. And so working closely with them and through our Humana Foundation, which is completely aligned with social determinant work that we on the Humana, the business side, do, are really working to make sure that capacity building is available to those organizations. To RJ's point around fee for service, have been talking with some of our partners around, what that might look like as we would think potentially about benefits in the future and, our formal filed benefits. And it's so hard to get to that, a competitive even dollar figure before that capacity building is able to happen. So, getting everyone on board to understand really what the landscape looks like and what the challenges are that these organizations are up against. And we've talked about it. We talked about on our prep session, things like contracting. These organizations are not set up to think about cybersecurity insurance and contracts and business associate agreements. And so using the resources that we Humana have to help understand that, to help them understand that, and to help make sure that all of those ducks are in a row for those types of contracting initiatives is another value that I think we as these large health plans can bring. I think we all see the same challenges and see the same opportunity that as we're able to partner more, as RJ mentioned, we have to have the data, we have to be able to show and prove the value because we know it's there. These are boots on the ground, they're in the communities, they're trusted. We could never replicate it. It's just a long game to get there and to prove that and to move from, this thought of, fee for service and how we kind of thought more as we would work with vendors before to RJ's point, really a value-based payment and paying them for the value that they're bringing.
And as you sort of mentioned that bit about how things are paid for, it's sort of really interesting. And it's great to have all three of you on here. And I think that John's angle on this, and I keep referring to it as an angle or a perspective, being in the opportunity zone space, puts you in another place a little bit here, because you being in that opportunity zone space is typically considered as real estate, really, more than anything else. You've taken a sort of twist on that and used the other elements of that 2017 Jobs and Tax Act legislation to spur capital development for businesses and other things that go into opportunity zones that may impact social determinants. So as I was listening to Jennifer talk about paying for the chef and everything else, you may be actually building out the space where you live with your family upstairs, and then your family member has a commercial kitchen space available to them to build a business, etc. Talk to us a bit about how that cross-sector of things works from your perspective. And I know I'm giving you like 2 minutes to do it, but see if you can do something with it.
I mean, it's fundamental to the work. I mean, anytime you're working in social determinants, Pierre, fundamentally, you're working with low-income people, and you are trying to leverage the existing community-based organizations that are already serving this population but need a lift up to do it bigger and better. In every one of our projects, especially given, that we are an opportunity zone fund and there's a very big mandate around economic development and all of our investments in job creation and what we're doing to really firm up the economic fabric of an underserved community. The key to that really ends up being incubation and support and capital for the community-based organizations that are already there to help them mature, to help them scale, and to get on this path to value. As you were saying, it's like these are folks that are doing this work right now, either out of the goodness of their hearts or on the basis of grants and philanthropy. It's a whole other mindset to get them on a path to value, where the work that they're doing today, say a dozen lovely church ladies in a basement somewhere preparing 100 meals for delivery the next day, we need them to get to 2,500 meals a day And, you know, we've got to be able to provide them with all the critical infrastructure that they need to be able to get there, the sophistication and the scale and the capital. Just like we're trying to bring physicians and other healthcare providers on the path to value, you can't ask these nice church ladies to make this giant leap in their own business evolution, you know, using Excel spreadsheets any more than we could try to drive value-based payment with a big physician group that we're trying to move out of fee-for-service. So it really is a lot of the same infrastructure that's involved. But, you know, when you're trying to help out the church ladies, infrastructure means stuff like broadband, so that they can actually, you know, connect to, say, a data hub or a software platform for their business operations, or a common billing platform. That they're going to need refrigeration. They're going to need the very technical process of packaging food for delivery to a huge audience of people. Then, you know, your whole distribution channel around the vehicles and the maintenance of a fleet to get that food to the people who need it the most when they need it. All of that stuff is critical. So there is a very central incubation feature to this. And as you know, as an opportunity zone fund, we of course have to pay mind to, you know, place-based investments as much as we can. So we look at a lot of projects and are involved in several where we're constructing commercial kitchens. We're acquiring or leasing real estate to you know, help support a large intervention. We're organizing or managing fleets of vehicles in order to, say, take patients to doctor's appointments during the day, but then drop off meals and prescriptions at night. So there's a huge, just an incubation imperative in doing this kind of work in every single project.
Right, absolutely. Yes. So, I mean, I think there's so many different ends or elements to it. I just find it fascinating that the way that you all go about it in the opportunity zone space opens you up to so much, I think, that may not be as easily accessible to others, but you can play on a number of different fields at the same time. Let's go on the next question that we had, which was, it's obvious, and I think to a lot of different people who are on the attending this know that health is very complex, and that sort of goes without saying, but it's interventions in social determinants of health themselves are not necessarily as sort of easy as one might think. And I think RJ spoke to it a bit earlier on with the backpack program and how resources put in the backpack that may have been for the kid who carries the backpack end up being used by multiple people in the family. So with that in mind, what approaches do you take to ensuring that the interventions you refer for are used as intended? So, or for a food program, for example, is meant for me because I'm the CHF patient who just came home from the hospital, then I'm not eating the food, or I'm not eating enough of the food. So I get readmitted maybe a little sooner than I should have been, folks get dinged, etc. How are you ensuring that that your intervention gets to the right person in the household where there may be a number of different needs that need to be taken care of at the same time? And RJ, because you mentioned that backpack piece, I'm gonna start with you there.
Yeah, sure. I think I kicked us forward a little bit when I answered that, but that's a good example, right? So one of the things we did with Feeding South Florida, and this started even way before Feeding South Florida, we actually sat down with Feeding America National probably a year before we even did that, and we had to get to like what should we do? Like we wanted to do something, and we said, what should we do? And so we kind of narrowed it down to get to the and great advice from Sandeep Wadhwa, who I'll shout out, former Colorado Medicaid director, who was helping advise Feeding America on how to engage with, with people like me at the time, and said, if you want a real social determinant, it's how kids perform in school at the elementary school age, right? Like, so it's actually high school graduation rate, but to borrow from the kickoff, you got to go all the way upstream to if they're not getting the fundamentals hit in elementary school, you're not going to have a high school graduation rate. Couldn't be more evident at the school that we chose to do this at. So, I mean, thanks to, it took the point there is it took 5 partners to get that done: the school district, Feeding South Florida, us, on and on, right? And the academic study with it. But the great advice we got from them was to design it around the family and to involve the families. John talked about this earlier. We were in basically central Miami, right near the Miami International Airport there. You have to be culturally appropriate. We'll be putting our actual report out on this soon, but the focus groups were conducted entirely in Spanish, right? None of the families that signed up for the focus groups, the parents or the grandparents, speak English, not even as a second language, really. The kids were fantastic. So great job with Miami-Dade School District there. But we had to design it around the family so that those things were culturally appropriate. We're doing the right, so that they'll use the food. And then I'll say on the kind of the second part of this question is the kinds of things we're getting to now is measuring this. So in your case, we have this very specific case with our Medicaid population in Philadelphia, where we are doing home delivered meals, and we are measuring their rates of readmission and how it's affecting the quality. So if it's not showing up as somewhat expected for readmissions, we know there's some issue there. I think that goes to when you're doing the intake on the members and when you're finding out everything about them, you've really got to know what those family and living issues are and have that documented and have the case managers empowered to solve for that as well. And then one really cool approach that we have in a couple of places is we do have Meals for Wheels empowered with iPads and going out to those members' homes. And so you're able to get a lot more data and a lot more information on what's actually happening at those members' house from a social standpoint. And that's that's a non-clinical person there, but you can at least figure out kind of what's going on and then not get that back to you, but it goes directly to the case manager, which is exciting.
Jennifer, any thoughts on this element of things and targeting interventions?
Yeah, I think, similarly to what RJ was saying, these eyes in the home, these non-clinical eyes in the home, this trusted resource. So we've done some work with Papa in Tampa Bay area. I know Andrew Parker was on, I think, last week. But the value that those Papa Pals provide and what they see in the home is very similar, and being able to report that back to our case managers, because we deal a lot, more in the Medicare Advantage space. So we have a lot of, seniors, obviously. So it might not be as easy to identify that family unit, because often if that family unit is senior grandparents caring for grandchildren, they might be hesitant to say that they've got 3 grandchildren that they're caring for, because there might be, some issue that they don't really want to raise attention to. And so whenever we think about addressing these needs, is really thinking about screening, understanding the full situation, and then within our interventions, but also within where we are connecting these members to. So for instance, screening for food insecurity, connecting the member or the patient to the food bank, along with the intervention that we might be providing, to make sure that we're thinking about this holistically and thinking about everyone within that house holistically and how we can address their needs. Another way that we have approached this is in 2020, this year, we filed a benefit that was a healthy food card. And so really, instead of us providing, let's say, a week's worth of food to Mrs. Smith, we are providing essentially additional financial resources for that member to bridge that gap between maybe what their SNAP and their financial income covers with groceries. And so what we hope to learn from that is exactly your point, Pierre. When we provide meals, we don't necessarily know who's eating them, but if there's an opportunity to purchase groceries, that actually can, at the end of the day, I don't know who eats the food that comes home, but if that's making sure that a grandchild is eating, is getting the grandparent to eat as well, and no one's going without, then I think that we have a win within what we're trying to prove with that benefit. So just a couple of additional examples and options.
Just that, again, this is another area that really speaks to the power of that upfront analytics and the screen that you should do with anybody that's going into any sort of social determinant intervention. You got to really have those eyes on the ground and know what's going on in that household through your analytics long before you ever darken that doorway. There are lots of ways of making sure that interventions are going at least to the right household. I think every time that you see a detoured intervention, like a diabetic meal going from the intended Medicare Advantage beneficiary and instead is getting eaten by her grandchildren, is a failure of the screening process up front. If Mrs. Ramirez is going to be getting diabetic meals, 30 a week, we need to know that she has 3 grandchildren on site who are also food insecure, and bring them meals as well so that Abuela can get the meal that we prescribed her. I think once you take those kind of upfront steps to do your screenings, the actual detour or misappropriation of these kinds of resources is actually pretty rare. The one thing to get concerned about is, of course, with prescription drugs, and especially with opioids. And there are ways of dealing with that. Like, we're seeing all these smart pill boxes now that, frankly, I think if anybody's getting prescribed opioids and they have social determinant factors, they should probably be getting them from a pill dispenser that's chained to a radiator somewhere in their house.
So good point. So the questions that are coming to us from the audience, a couple of them in particular, focus on impact. And so these interventions that we're talking about are all great, but they're all for nothing if they're not actually driving some sort of impact. So questions from both Darcy, sorry, I will make sure I'm getting names right here, Darcy Knowles, as well as Dr. Lisa Fitzpatrick, relating to impact and how you are measuring outcomes as a result of the work that you're putting into these social determinant spaces. And are you seeing improvements in readmission rates, reductions in readmission rates, or improvements in clinical metrics for the diabetics, et cetera? Are you able to speak to any of that with respect to the work that you're getting into? And if you would, Jennifer, if I can ask you from your perspective of Humana, and then I'll come to RJ and then to Joe.
Yeah, so I would say the one thing that we all need a little bit more time is, what we all need a little bit more of is time. So these interventions take, a long time to measure. And so whenever we look at any intervention, any pilot, measurement's the key. We have to prove the outcomes. We have to prove the value. So we use the CDC's Healthy Days tool and really, whatever appropriate domain related to social determinants. So if I'm, beginning really pilot, test and learn concept, can we improve food security through a pilot or an intervention? Typically starting with Hunger Vital Sign 2-item screener and also Healthy Days. But then in addition to that, that's not going to really truly show the value that we were able to improve food security. Looking at those clinical metrics, things like, we've mentioned ED visits, readmissions, admissions. I always like to make sure that we're looking at medication adherence because, do we think that, so I'm always in the food space. That's just where I naturally gravitate towards, but is that financial strain of food keeping a member or a person from getting their medication refilled? And so those are some of the clinical metrics we look at. I would say directionally we're seeing improvements, just kind of back to this point of we're really taking the time to allow the interventions to be appropriate length, knowing that these people, they've probably eaten like this for 50, 60, 70 years. And so just a 12-week intervention is probably not going to turn that ship immediately. So giving that time and really working with our leadership teams to take that time, but seeing directional improvements and really look forward to talking about this a year from now to see how that might have changed.
RJ, from your perspective, measuring outcomes, how are you going about doing that?
Yes, first of all, Jennifer mentioned this earlier, but I'll just go ahead and say it. I think these questions were planted by our bosses. on on how do you get to ROI right away, right? So that's the question at hand. Is this all worth it? And my answer is not going to be that different. Give us some time. Our SDoH department has been around for less than a year. But I will say, and that doesn't mean that we haven't been looking at it beforehand, but we've just gotten an enterprise view of it since. I will say, we do have the things that have done pilots or experiments, or not even the food one I mentioned in Pennsylvania is not even a pilot. I mean, it's just an ongoing thing that we do for members that hit a certain criteria, and that works. We have great data back on that that we can share. We've actually shared it at other conferences. So yeah, there's a lot more to come. I do love, especially with CVS, being part of CVS, medication adherence is a fantastic one for us to be tracking, and we're really thinking about how does this work across the whole CVS enterprise, from pharmacy to the Aetna member. How are we going to have people show up in health hubs that are not Aetna members, and how are we going to? There's a very strong desire to engage social determinants in the communities there at the CVS health hubs. And then how do we measure that, which is different than how you measure it on a member that you insure, right? So all of these, we're learning as we go, but we're getting there. And I think the ones that we've done so far, most of it's been right where we thought. I will say there's been some, again, I mentioned this before, but there's more variables than you could ever possibly imagine. And so you really have to design interventions that get at all of the social determinants, or again, the whole family. But yeah, we're bringing the measurement along, and the measurement exactly of these exact social interventions is not perfect yet, and it's not super easy, but we're getting there for sure.
I'm going to keep you on the hotspot for a second here, RJ, because there's a couple of questions, and then I'm going to come to John about the follow-up to that. But a couple of questions being asked about you mentioned Unite Us and Socially Determined as being partners. And so Maria wanted to know, is there any part of the SDoH stack that you're missing at this point? She's asking that from the perspective of someone who's involved in building software-driven startups. So that's sort of self-study. It's a great question, and sort of add a little part two to that, which is from Mr. Patel, who says that he's asking about the vendors that you use to build those community resource networks, which would be a Unite Us, for example, and how are you embedding the data points back into your payer organization workflows? So what are what's missing, and how are you building that data back into workflow?
Fun question. This is the hard part, right? So I decided that this was the way to put this together. So yes, we use socially determined. We also have. I should give a shout out to our internal data team. We do have really good internal social determinants data. Reasons I don't need to go into on here. We don't have it for our Medicaid platform. It's our Medicaid members on this particular instance for Unite Us. So we're the way that works, and this is ongoing, and our friends from Revel here are helping with this, is that we'll take the data, exactly as John mentioned earlier, actually down to the individual member level, which is actually one of the more exciting things I've been doing in social determinants, is to have a score on a member level, and be able to then ask Revel to turn that member to the platform. So I don't want to add any more complexity to that. That's a bunch of exchanges, and the IT folks love me for that brilliant idea. So if there's anything missing, don't tell me about it yet until we can figure this part out. But I'm excited about getting into that project in our 3 Medicaid pilot states to get it to work, and what we can do with that. And then separately, where we don't have referral platforms yet, how do we use that data about not only the communities, but the members themselves down to the individual level to drive what interventions are needed in the social determinants arena. I think that's, so again, I don't think there's anything missing. That's that's my vision of how it works. We're building it as we fly it now. It should be super interesting to see how we turn out here. And then I will say the best part about, one of the better parts about this is from Revel. We're super excited about them being able to return data to us on improvements in the Medicaid members. What do we, how can we better contact them? What's their preferred method of contact, which is always a chase for any member, especially difficult for Medicaid members.
Wanted to ask you, John, I know you've got a long history in the population health space, obviously worked with plans for a long time and now in this opportunity zone space. There's a question from Philip Giordano here. This is asking how can primary care help gather social determinant of health data and information in the most effective way so that it makes its way back to the MCO and community organizations to assist. So do you have any thoughts on or examples of how primary care providers are facilitating getting that information to the plans?
Sure. Even back to the prior question, let me get to Phil's in just a second, Pierre. Man, if you guys think a HEDIS auditor is tough on outcomes metrics, man, try a Republican billionaire investor. Man, I thought I knew what a proctological exam was before this, but man, when these investors start coming at you for the results that they're going to get for the money that they're sinking into these projects, man, you better have the right numbers to show them. So from our perspective on the whole measuring outcome stuff, I mean, we have to, every single investment we go into has literally dozens of performance metrics that also then have to be overlaid on what our plan partner is looking to achieve out of this investment. So of course you got to look at, an increase in HEDIS and STARS and CAPS scores going up. You got to look at, are you doing a better code capture rate on your risk adjustment assessments? All of those are metrics that are embedded in everything we end up doing. But then, man, if we're working with a Medicaid plan, one of the big metrics for them is like, is this going to help them score better on the social innovation sections of their next RFP response? So, we have to pay attention to this stuff as impact investors, and all of our projects are just, layered with multiple metrics of performance right down to the individual. And often it goes well beyond just the healthcare metrics. We're looking at social metrics. We're looking at numbers of appointments missed. We're looking at, how do they do on their last, their last cognitive function test, if they're experiencing severe loneliness or isolation. So it depends on the project, but you got to have those measures all throughout. Now, to Phil's question about how primary care can help around social determinants. Listen, I mean, there's lots of screening tools that are out there that are available to primary care practices. And I think it's absolutely critical and pivotal, and PCPs should get paid for weaving those screening tools into, an annual wellness visit or, their first annual checkup of the year. And that should be almost as robust an assessment of social measures that are self-reported as you see for clinical measures in a checkup. But I also tend to be a very strong believer that if it's falling to PCPs to screen for social determinants, we've already failed. That screening needs to happen in the first round through analytics, and then secondly through a live human interaction, preferably in the home. And to our way of thinking is both opportunity zone investors, but just as guys that do this every day now, the community health worker is the most represented, under-respected, undervalued asset that we have in our armamentarium. And any social determinant intervention should revolve around a huge group of community health workers that are paneled to a certain number of members, and they're stratified based on how much attention those members are going to need. They're the ones that should be doing this kind of screening in the home. It shouldn't fall to the lovely ladies from Meals on Wheels. That was a big transformation project we did with them a couple of years ago to just give layperson observation tools to the ladies and the folks who are going to drop off these meals during that 15 to 20 minute social checkup that they do. That should be being done by a community health worker or a promotore as a matter of course for every single member that you're intervening with on an annual basis.
Absolutely, absolutely. Jennifer, I think you had some comments related to this thread as well.
Yeah, the only thing I wanted to add is, so earlier this year, exactly to that question, we know that there's a report released, times run together at this point, maybe I think it was last year, PCP's not necessarily thinking this screening and this addressing of social determinants was their job. And so, weren't reimbursing them for it, what other than, when we can prove the outcomes behind addressing these needs, what really was the value. And so earlier this year, we started, we've got one pilot going right now with a health plan in Louisiana to reimburse for that screening and referral of social determinants in the primary care space. And so really interested to see how that goes. I will say, sometimes that data exchange back and forth can be the challenge in what we're figuring out, but we've started. And so really putting that fee, if you will, behind that screening and referral, which incentivizes the providers to do this, incentivizes the physicians. And I think that we will start to get that data from other places, including, where we have it, knowing that the physician is the trusted partner for the members.
And Jennifer, staying with you, and thank you for that answer. So in a nutshell, there's a question here from Diego about the assignment of priority funding finances to particular SDoH or chronic condition or geographic area. I mean, how do you go about making that assignment? I mean, you mentioned GIS mapping of conditions, and I'm imagining that community health needs assessments, and there are other metrics that come into play. What do you most commonly use to make the determination about what and where with respect to your social determinant of health interventions?
Yeah, so, I mentioned we have our markets that we know we have critical mass for membership, but that's one of the biggest pieces is where do we have that critical mass of members. We also work very closely with our leaders within our markets to understand their priorities. I mentioned we really believe that health is local. And so if Jennifer, sitting in Louisville, Kentucky, thinks that diabetes is what I need to focus on in San Antonio, until I have worked with that market and worked with the teams that live, work, and play there, I don't know the first thing that I'm talking about. And so working closely with those community leaders and our business leaders there, from a condition standpoint, really just looking to see what the data tells us. I think this is also why I referenced earlier our comprehensive screener, that we're looking really at that longitudinal health record related to social needs. But then in addition to that, what does that data tell us? What are the most prevalent health-related social needs that are compounding together, and then what impact is that having on certain chronic conditions? What do the members within that large sample look like? And how does that then help us determine where we should prioritize? Because, again, if we're not listening to the data and not listening to the people around us or the people that are in the communities, then it's just, we're not going to get there. We're not going to get to the high priorities, the highest priorities that we should be focusing on.
I wanted to, we only have a couple minutes left here. There's a really interesting question that has also come up. And I think that there's the data, and I forget who the quote is from. I think it's Einstein. Everything that counts isn't counted, and everything that's counted doesn't count. Something like that. It's a bit of a conundrum, but anyway. But then there's the data that we talk about very frequently that we've already been discussing. But then there's this other data that sort of, I don't want to call it more insidious, but it's under the surface data, information and circumstances that underlay all of our experiences, or many of the experiences that people in these communities have, right? In chronic trauma, low health literacy, distrust of the health system, for example. This is a question that's being inspired by Dr. Lisa Fitzpatrick's comment. And so How do you go about gathering any data or creating any analytical framework around that sort of information that is a little bit more difficult to gather? And so if each of you could sort of comment on that very briefly. I'll start with you, John, and then RJ, and then I'll finish with you, Jennifer.
Sure. Well, Dr. Lisa certainly knows her business. She's been in community medicine her entire career here in DC, and we love Dr. Fitzpatrick. There are a lot of factors that can be do or die in an intervention around social determinants that that can sometimes slip under the radar of even the best analytics that you can do. And that's where, especially in the age of this pandemic, where folks are feeling more isolated and cut off than ever, is really the power of a real human connection and a real human assessment and interaction. One of my past lives, we launched one of the biggest house calls companies in the country that today is Signify Health. And we just really saw firsthand that there is just nothing like being there and really being on the ground in a community or in a member's home to really understand the circumstances in which they live. And, Lisa's done, really street medicine most of her career. So she sees this every day. And she's exactly right that there just isn't any substitute for really getting on the ground to understand a community and patients individually. Fundamentally, this business, when it works the best, is actually low tech and very high touch. And I think that's what Lisa's really getting at, is that some of this stuff just doesn't come through in the data, and you just really got to get there and feel it and touch it to really understand how to shape your intervention in the most culturally competent way.
RJ, thank you.
Yeah, thanks. This gives me a chance to bring up two things that I was hoping to. I'll try to be quick. The first is back to the measurement. Yes, John, I absolutely agree with John, especially the general type of members that we're talking about, and to be there and to be local is super important. When we think about measurement, one of the things that we're trying to instill, again, before we go straight to like what's the ROI, is this continuum, right? And we're measuring now. Are we changing their food security and how many new social interactions are we creating, and how many, what are those things? One of those things on there that we want to measure is health literacy. I think we have a couple proxies for it. I don't know if we have anything perfect. Again, that does require some one-on-one. So I do appreciate the question on health literacy. Then the other thing I wanted to go to is, as we're building these networks, I actually had this conversation today, just a couple hours ago, with the folks that are at the front line of making these referrals into these social platform networks. And I said, well, are we doing enough to make the feedback loop of what I know it's not perfect. What are we missing from it? And they said, the most interesting thing that's been coming up is people that have been positive for COVID looking for like actual emotional support and actual just real support, like the kinds of cancer groups and the other kinds of allied groups that are out there. Something that basically doesn't exist yet, and we're trying to figure out how to get those members that kind of social and emotional support for COVID, especially in the circumstances that these folks are already in. We have some really great success stories for COVID positive members specifically from the referral platforms already. But that's something that's emerging now that is an indicator of the underlying not only health conditions, but the social conditions and the perspectives that everybody's coming into this from when they're already in a Medicaid health plan. They already obviously have social needs. How do they deal with having COVID when they're already struggling? So something that we'll definitely be working on.
I know we're at time, so I would, just completely agree with other comments that actual human touch, seeing what's happening in that home, what that real situation looks like, because, we've experienced post-discharge, for instance, that member is going to say whatever they can to get out of the hospital. Nobody wants to be there, but, that person taking care of them at home and making sure they're eating may or may not exist. And so until we see that, we really don't have that full picture. So that human touch is so important.
Well, we are at time. Thank you very much to all of our panelists today, Jennifer, RJ, and John, for your engagement with this and prep and run up to it, and great responses. Thank you to our guests who came in and asked some fantastic questions, and I hope this was a good session for those of you who stuck around for the duration of the hour. And with that, I will pitch it back to Ryan at Revel. Thank you.
All right, thanks, Pierre, and thanks again, John, RJ, and Jennifer. Great session, great way to cap off Rev Up 2020. Again, we look forward to seeing everybody next year at Rev Up 2021, hopefully in person. Panelists here for you. So if you have additional questions, it's a great way to reach them. Again, also, if you don't take a screenshot of it right now and forget or whatever, you can also reach out through Revel. We can get you connected with the different panelists. As a reminder, the recordings are going to be available on revupshow.com. So if there's anything that you are scribbling furiously to try to create your manual, your how-to book for setting up an SDoH program, you missed something, go on back to the recording and check it out. But again, thank you everyone for a great series. Thank you for all the attendees for joining, and we look forward to seeing your comments as you exit. Don't forget to fill that out. But thank you everybody.